So surgery came around in the 50s with an old jejunal ileal bypass. It was really simple, just bypass parts of the intestine, and by the way, it worked. Except a few years later, people started developing complications, kidney problems, liver problems. When I was a resident, I saw 2 people die with this. Two women die because they went into liver failure from that operation. So that's not done anymore. In fact, it's recommended to be reversed, and I've done that a few times, but most patients who have this aren't around anymore. In the 60s, open gastric bypass came around. In the 70s, a gastric band, not the adjustable lap bands that we're talking about, but gastric band. Gastroplasty, vertical banded gastroplasty, and a complex operation called a pancreatico-duodenal switch, okay, or pancreatical bypass. It's complex. It's associated with the most amount of weight loss, but it also has the highest risk. In the 1990s, laparoscopic gastric bypass came around. In the late 1990s, I did my first one in 1999. There was a lot of controversy at the time about whether an operation that complex should even be done laparoscopically. There were a few of us who trained in that era of laparoscopy who were used to doing big operations, and we knew it was better than making a big cut down the belly, right? But a lot of surgeons started to develop an interest in it because there were a lot of patients who wanted to have it done. And so it didn't take very long until there were complications, and some of those hit mainstream media. And I can remember the CNN streamer of seeing boy who dies after gastric bypass, okay? And so it's this big deal. The lap band came out right then, okay? So the lap band was safe and adjustable. You can control it, right? And so there was a lot of play for it. I want to be candid with you, I was never very excited about the lap band to begin with. I'm qualified to put it in. I did put some in early when the option was just a bypass or a band. The patients uniformly were not satisfied with the amount of weight they lost, and the longer they're in, the more problems we see, and I'll tell you a little bit about that. And then in 2000s, the gastric sleeve came around, laparoscopic gastric sleeve. I did the first one around here in 2005, and the reason I did it was because it made sense. There's as much weight loss as you get with a bypass if you have a healthy lifestyle afterwards without all that risk that goes along with it, and a lot better with the band. The beautiful thing about the sleeve, believe it or not, you have it, you change your habits around a little bit, and you get on with life. You don't have to worry about metabolic problems and taking supplements and coming back for adjustments or some of the issues with a gastric bypass, ulcers, bowel obstructions, weight regain, which I see not infrequently with gastric bypass. So here's the current option. So gastric bypass today, laparoscopic gastric bypass, long history, lots of information about it. I've published a lot of this, but it's falling out of favor, and it's falling out of favor because the sleeve's a better operation, to be honest with you. But there are a few instances where I think it's still a preferable option. Adjustable gastric bands, you lose less weight, there are long-term issues. I'm going to tell you more about that, and it's falling out of favor. The band has dropped in terms of the number of procedures performed in the United States by about 90%. As I told you, this is a more complex operation. There's more weight loss, but it has the highest complication rates. And you have to be followed very, very closely with this operation. As mobile as our society is, you can't have this operation and move to another city and not have a physician who's familiar with the blood work you need to have and the supplements you need to take, and then this gastric sleeve. And the truth is, it's simple weight loss similar to a gastric bypass, and that's why it's become so popular. So here's the bypass, just so you know. This is the esophagus. We create a little pouch right here, so all of this part of the stomach is bypassed. The intestine has been cut right there and pulled up and hooked onto it and called a Roux-Y, right? Roux-Y, because Roux is the surgeon who described it. By the way, in the 1800s, a French surgeon, had nothing to do with weight loss. And it looks like the letter Y. That's where it gets its name. Again, decreasing popularity. The operative risk is higher than it is with a sleeve, and it depends on who does it. I'll be honest with you. If you're interested in a gastric bypass, don't let a surgeon who's done less than 100 operations do your surgery. There are all kinds of little pitfalls involved with this. There's long-term risk associated with it. I'm going to tell you about the Milliman Care Guidelines a little bit later. And the Milliman Group publishes the standard of care that most of the insurance carriers, as well as Medicare and Medicaid, follow. But I do think it's good for poorly controlled diabetes. For some reason, food going past this part of the intestine seems to decrease our sensitivity to insulin. When you bypass that and the food's going around it, the diabetes improves immediately. Most patients, if you're on insulin, will half the dose. If you're on an oral medication for diabetes and you have a gastric bypass, I stop them the day after surgery. You're off them. Now, in the end, there's no difference with a sleeve and a bypass. After several months, the resolution of diabetes is the same between the two, but it's a lot faster in gastric bypass. So for poorly controlled diabetes, I think it's not unreasonable, but here's some of the complications you can have. You have to pull the small intestine up around the colon to get up to the stomach, and so there are little gaps inside. These are called internal hernias. I published this data. This is an example of an internal hernia and where the bowel is completely obstructed. It's gone in that gap and spun around. So crampy abdominal pain, it doesn't get better. It especially happens after you eat, and it can be a surgical emergency. Your bowels can die from that, and I have personally seen that. Fistulas to the old stomach. The old stomach and the pouch are sitting right next to each other. So believe it or not, sometimes they grow back together. And here is an example, the esophagus, and here's the pouch, and this is the beginning of the small intestine, and here's dye going down into the old part of the stomach. So when you look at it with an endoscope, okay, we're putting down an endoscope, this is the normal opening down to the small intestine. That shouldn't be there. Food's going down into the old part of the stomach. And the problem with that is that acid from the old part of the stomach will reflux back up, and this does not like that, where the small bowel is hooked on. And it's just a matter of time if that happens, you're gonna have a complication with bleeding or perforation. And so those really should be fixed. And as a matter of fact, just before, I took a vacation here recently, but on the way out, I got called, old patient from Baylor, who they've been treating with a gastric fistula for 2 years. And guess what? That's the night he perforated, right? And so it really does happen, and I think it's a surgical issue. You can have ulcers that occur. This is an ulcer on where the small intestine is hooked onto to the small bowel. That's what it looks like on an upper GI and on a CAT scan series. Gastric bypass, you really cannot take non-steroidal anti-inflammatory drugs or you get ulcers. If you drink alcohol, it's magnified by about 3, because alcohol is going straight into the small intestine. If you have 1 glass of wine, it's gonna feel like 3. So there are some limitations to that, and these are the issues I was telling you about. But with all of the fear, out came the lap band, and this is what it looks like. It's a band that's wrapped around the upper part of the stomach. It's hollow, okay? It's like an inner tube, and it's connected to a catheter that goes down here to a port, and this port is put underneath the skin, so you can stick a needle through the skin into that port and inject fluid and blow this up, okay? And cinch down the stomach. The popularity is decreasing. It does have the lowest operative risk, okay, compared to some of the other operations. It's the easiest to put in, although I think with the mini sleeve, you'll see that it's very comparable. It does require invasive adjustments afterwards, and it's amazing. I'll show you some pictures. Depends on how much fluid. The old ones used to hold about 4 cc's, some of the new ones 8 or 10 cc's. When you get close to it being properly filled, it's a difference of 1/4 of a cc. Can make a huge difference. You can go from not feeling any restriction to be completely obstructed really easily. So sometimes it takes a while to get it adjusted properly, and if you lose weight and you lose fat around it, then it has to be adjusted again. The problem is that it's not doing anything about ghrelin in the stomach, and by the way, neither was gastric bypass. So ghrelin levels increase. This is essentially a partial obstruction of the esophagus. That's what it is. That's how it works. And so the muscles of the esophagus are trying to push against this fixed obstruction, and they're not very strong, and they get tired, and the esophagus just kind of, it's called esophageal dysmotility, wants to just sit there. Reflux is really common. Less weight loss, slower weight loss, and the long-term risks are increasing. And I'll show you some of these. The biggest issue really is we don't know what it's like to have a band in for 20 or 30 years. It's made out of silastic. The biggest problem is going to be they're going to stop working, they're going to stop leaking. And when they start leaking, it's really hard to diagnose. By far, this is the most common operation that we fix. And so you got to put it in a way that you minimize the risk, and that means around the upper part of the stomach, it gets wrapped over the top so things can't slip underneath, but even when you do that, it can still happen. This is a slip underneath. That shouldn't be there. The band is right here. This should not be there. That has to be fixed. And I've seen patients come in, I've had patients actually from Mexico who come in and the top half of their stomach is dead. And that's a problem when you've had your surgery in Mexico. And I can understand cost-related issues, but when you come to a U.S. hospital with a complication like that and the insurance company says, no, we're not going to cover that, so it really turns into a hassle for them. This is the way it's done. It's done laparoscopically, similar to a gastric bypass and a laparoscopic sleeve. Here's the band itself. The band was made by Allergan. Allergan has now sold that to Apollo Endocare. Not that Apollo wanted that, but they had a balloon, and so they got the balloon out of it. But here he is stitching the stomach up and over to try to fixate that so it won't move. So this is what it looks like when you have a band. You come in, we do an x-ray, there's the band right there. And here's the tubing that goes down to the port that's right underneath the skin. And this is, and I'll show you this, normal lap band with good restriction. There's the band, there's the restriction. You see it? This is the beginning of the stomach. Let me tell you, that esophagus is far from normal. That esophagus is 5 times the size it should be. And so here's a normal esophagus, okay? Here's an esophagus with the band properly inflated. You see the difference? You see what I'm driving at? So what can happen at night when you have that, what can happen at night, is you lay down and you got all this fluid in your esophagus. So you aspirate, and so sometimes patients, when I see them, I ask them, do you have a hoarse voice? And they're like, how'd you know that? Because it's aspirating back onto the vocal cords. And it can aspirate down into the lungs and cause some real problems. So here it is, again, a normal band, meaning no fluid put in it, even though it's a little dilated. That's a complete obstruction. And I'm telling you, a little bit of fluid can do that. And so adjustments are always kind of a part of a lap band. They can erode through the stomach. The longer they're in, this is looking from the inside of the stomach. Okay? The wrap has been pulled over that, so nothing leaks outside. What happens is the port gets painful because bacteria are following that catheter back, right? And so that's a different, now when we go to fix that, that's a little bit more complex because there's a hole in the stomach. And even then, we have been very successful in just changing it over to a sleeve and resecting that part of the stomach that's perforated. And here you go, and here's a leak. This is a hemostat on the end. We're having to force fluid through it, and that's the leak right there. And so when you get a leak, you get a fill, and it works for a while, and then it kind of stops working. It's slow, and so you can't, there's not a way to image it. It's difficult. So duodenal switch. As I said, this is more complex, but what's interesting is a duodenal switch, part of that operation, this part of the stomach, that's a sleeve. And that's really where the sleeve derived from. But in the duodenal switch, a long part of the small intestine is bypassed. And if your food's not going through there, sure, you can't absorb the calories, nor can you absorb the vitamins and micronutrients, right? And so metabolic problems become a real issue. You lose a lot of weight, but metabolic problems become an issue. Highest risk, metabolic deficiencies, you gotta be on lots of supplements, and you have to have stringent follow-up with your physicians. And as mobile as our society is, that's difficult to do, in my opinion.